all of us that are parents of children living with diabetes or have kids or adults, we would change places with them at any time. And we've all had that conversation where the kid goes, Mom, I don't want to take any more insulin. Please make it go away. I wish I had a magic wand and would just take it. I would gladly live with it and not have her go through it. And it's painful. It's very painful. And as a doctor, I don't think we are able to understand how painful it is until we live it, as a lot of experiences in life. And there's a lot to be said about how these kids have to grow up a lot. And sure, because they have to take choices all the time and make decisions all the time. And these decisions literally can kill them. So you have this incredible responsibility as a kid. It has to do a lot of at what age you are diagnosed, because if you're very, very young, then parents go crazy because that kid is dependent completely and you have no way of knowing what they're feeling. And if they're a little bit older,
Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights. Hello, everyone, and welcome to Global Diabetes Insights. Together with us, we have Dr. Ramos today. I would like you to introduce yourself before thanking you for being with us here and giving this dialogue about diabetes.
Hi, Kona. Thank you for inviting me in Global Diabetes Insights. My name is María Alejandra Ramos from Honduras, which is in Central America. It's actually the center country of all America. We are right in the center. My country is a country of about 10 million people. Spanish is our first language. We have very warm weather with a lot of rain. We have beaches. We have a very diverse landscape, which makes access to medical services very difficult because we have very high mountains and we have very recluded areas where you have to travel more than 10 hours to get to. I am endocrinologist, internist, adult endocrinologist. I've been married for 20 years, not to a doctor.
That's a clever choice.
Yes. I have two kids. One is 15 and one is 10. And my 10-year-old debuted with type 1 diabetes 2 years ago. It's very interesting because I have a little bit of knowledge of the two worlds.
Yeah, we'll get into that. I would like you to explain what got you into endocrinology. I consider the endocrinology as an elite specialty because not many people choose it. Also, many people into endocrinology have a first-hand experience in their lives, but I hear now that you had this experience after choosing endocrinology, which is even more interesting. But yeah, first of all, why did you choose over the wide range of specialties endocrinology?
That's a very interesting question because since I was a kid, I've always wanted to know how things work. I was the kid who would open cockroaches to see what was inside of the cockroach. So I've been very curious and I decided to study medicine. Because then in medicine, I discovered that it was a service profession where what we do more than the scientific part, which is obviously still very interesting to me, what we do impacts directly on people's lives. So then after medical school, which in my country is 8 years, I decided to go to a specialty, which to me, in that moment, the most as far as understanding how the body works. So that's why I decided on internal medicine. Then I was just married when I finished internal medicine. I was very worried about my reproductive future and how I was going to be juggling being a mom and married. And I decided to look for a specialty that I thought that could give me time, that would allow me not be in the emergency room at 2 a.m. In my country, at that time, there were in my city, which is the capital city, only 4 endocrinologists. I actually was the first woman adult endocrinologist in my city. And I was the fifth person who was before me. He's about 4 years older than me, but the next one before him, there were 25 years when we didn't get a new endo in the city.
Okay.
So we had two different generations. So when I came back, there was me, 28, 29-year-old woman, and two 65-year-old men who were trying to interact in an endocrinology service. Guess what? Endocrinology doesn't get you at 2 a.m. in the emergency room, but I am very busy.
Yeah, that's what I was going to say. You were a bit mistaken about the quality of life.
Yes, about the idea of life. I don't know about the quality because I really think that has a lot to do with mindset more than time. I do have the two kids. I do spend time with them. I juggle like any other mom, but I do not go to the emergency department at 2 a.m. If I'm home, I sleep. But the idea that I was going to have off time, that didn't work.
Yeah, for any young doctor who can hear us, if you want to avoid or not the emergency department is indicative of what specialty you can choose. You can trust this question to take off many specialties and decide where you would like to go. I think it's a nice question. Do I see myself in the emergency department like when I have 2 kids or family? And as we said before, 2 years ago, one of your kids was diagnosed with type 1 diabetes. How did you experience that? You have managed many people with type 1 diabetes. You know type 1 diabetes and you know type 1 diabetes professionally. You know the mechanisms of the body, the physiology, the pathophysiology, but how it is to apply this knowledge when the sentiment influence you because it's your own child.
Well, Kona, I thought I knew diabetes. I've been working as an endocrinologist for 14 years by the time my daughter debuted. So I thought I was very fluent in diabetes. But guess what? It's not. I mean, there's diabetes from the doctor's side, and then there's diabetes from the patient's side. And then there's diabetes from the caretaker or caregiver's side.
Most difficult one, because I think the caregiver sees their favorite person struggling or having to deal with that, but they don't know how to help the individual exactly. And I think that's more painful than experienced diabetes, because when you experience, you just know how to do things and how things work. But seeing your kid having to do all the processes about diabetes must be more painful and difficult as a mother of type 1 kid.
I completely agree. And all of us that are parents of children living with diabetes or have kids or adults, we would change places with them at any time. And we've all had that conversation where the kid goes, Mom, I don't want to take any more insulin. Please make it go away. I wish I had a magic wand and would just take it. I would gladly live with it and not have her go through it. And it's painful. It's very painful. And as a doctor, I don't think we are able to understand how painful it is until we live it, as a lot of experiences in life. And there's a lot to be said about how these kids have to grow up a lot. And sure, because they have to take choices all the time and make decisions all the time. And these decisions literally can kill them. So you have this incredible responsibility as a kid. It has to do a lot of at what age you are diagnosed, because if you're very, very young, then parents go crazy because that kid is dependent completely and you have no way of knowing what they're feeling. And if they're a little bit older, it's a little bit more easy because they will obey, they will cooperate. But then if you have like teenagers, it's difficult. Like every age group has their challenges. But I think that what I've learned as a mother is that there's a lot more things than what you eat and how much insulin you take that determine your blood glucose. So that A1C, first of all, is not a measure of how good you are at managing your diabetes. It's not a test of how good a person you are. It doesn't measure how well you are performing. It's not a performance indicator. It's an average of so many things going on that even if you are following a very strict diet plan, even if you are exercising, if you get sick, it just changes. Like if you get the flu, if you are very stressed out, if weather changes and you're dehydrated, more than 50 things that will influence your blood sugar. So I think I wasn't aware as an endocrinologist how many other factors. I was a doctor who kept back of my mind. For example, older diabetes patients would come and say, oh, doctor, my blood sugar is high because I'm very stressed because my son is going through a divorce, for example. I would be like, yeah, but it's not 13. that's not making your A1C 13 in the back of my mind. And I think I was very judgmental, and I've changed that completely. I am more empathetic because of the fact that I've seen it in my house. Hey, we're doing everything we can. Puberty just hit. And well, there you go. Then everything you thought was going great no longer works. So I think that that's the biggest lesson I've learned, to be a lot more understanding.
It's very honest of you to confess and say that you thought you knew, because the variables in diabetes equation are just uncountable. In order to have a balance, you just have to rethink, readapt, change the way you behave towards diabetes. That's very interesting, because from what you say, medical knowledge is not enough. I always say that endocrinologists, healthcare professionals give advices, but I think if they could maybe virtually experience one day as a person living with diabetes, their perspective would change so much, because saying that you just have to eat right, count your carbs and stuff. And if you see that in action, this does not work many times, and many times you have a reason, but there are some days that you do everything right, still you don't have the result you want. And I also like to underline that A1C doesn't define you, because many patients and people with diabetes struggle with numbers, how good of a management they have, and this result is good. It's healing hearing from a doctor saying that it's not something that defines you. It's just an indicative of if you need to change something to get some better results.
I think that the word you've just used is very powerful, define you. When my daughter got diagnosed, I think that privilege I've had is of course, I have a lot of contacts. One of my endocrinologist friends from Mexico got me in touch with a diabetes psychologist. So we had a meeting 3 or 4 days after she debuted as a family. And my then 13-year-old son, when we had this talk, we were all in mourning, because you are in mourning of the healthy kid you had and the life you had, because everything changes. All of the family goes through that mourning. You have to understand that process is necessary to get to the happy new normal life. So you have to change. And when that happens, you feel sad, and you have to acknowledge that. So my 13-year-old, when the psychologist, we were ending the conversation, he said, "What do you have to say to your sister?" And he said, we call her Piti. And he said, "I just have to tell Piti that this doesn't define her. This is something else in her life, like her curls. This is something she has to learn to live with." My husband and I were heartbroken. And then there's this kid with so much enlightenment. He had it all figured out. Of course, it's very easy to say, but very difficult to grow into. But it's true. I'm determined to educate medical professionals, especially endocrinologists, in trying to stop judging, because we judge patients, and I do know that patients feel judged, and I've done it. I'm sure that part of the purpose in my life for this thing to happen in our family, because I am able to change the way that disease is approached, at least by the people or the professionals I come in contact with.
I appreciate that, and I feel honored that you transform possibly traumatic experience to motivation to change something and to see the other perspective of diabetes, which is the patient's side. I agree, but I want to say that at least at the age of your daughter's diagnosis, technologies were more advanced. I don't say to undermine the seriousness of the diagnosis, but I think that at least she's 4 steps ahead of people who were diagnosed, let's say, 10 or 20 years ago. So her treatment, her result, her overall health is from day 0 to a much better quality than kids some decades ago. And I wanted to ask you 2 things concerning that. Now, as a medical professional, mother of a kid that has a medical condition, but also as an ex-medical student, how do you experience the medical healthcare system in Honduras? Concerning type 1 diabetes, which technology advances do you underline and appreciate both as a healthcare professional and as a parent?
I do believe that we are very lucky for her to have debuted in this day and age. I feel privileged in many ways. This is something that I've always said, that I am very lucky to be an endocrinologist in a time where we have a lot of options for treatment for patients with diabetes. And we have a lot of technology that makes our job a lot easier. Just the ability to communicate virtually during the pandemic, for example, I gave a lot of Zoom consultations. I have telemedicine in my public hospital and in my private hospitals. Just the ability to get to the patients with more ease makes a lot of difference. The ability to get a WhatsApp message or an email and you can adjust your dose or get education through that. The amount of information that is available online for patients and for their caregivers and for the doctors is amazing. And I think that all of that has contributed that we are changing what used to be the prognosis of a person with type 1 diabetes. That is all true. But also in my country, there's a lot to be said for inequality. Of course, as a professional, I have the ability to get my daughter better health care, technology and CGM. I think that possibility of doing that is not available for most of my patients. And I've advocated for my patients before her diagnosis. I've always been trying to get better insulins, for example, to get insulin analogs in the public hospital system and just to get them the glucose meters and get them strips and work with the Diabetes Foundation, my local foundation, to get resources or funding to support this kind of initiatives. But all of that is just little blocks like a Lego, like building blocks that we all need to work with. I think that if doctors are not educated in how important these new technologies are to the quality of life of the patients, if we don't insist as the idea that there is medical evidence of reduction in chronic complications, microvascular and macrovascular, with better control with technology, we need to get that out there. For the last 2 years, I brought the first glucose sensor to the country. I started importing them and trying to get more doctors to use them and training doctors. I've been during the last 2 years giving talk everywhere I'm allowed to on how to use the technology and how important it is, the technology. The value of a night well slept for a mom or for the diabetes patient, because you are no longer worried that you're going to have a hypo, because if you do have it, an alarm is going to sound. That value, I don't think that we were aware as doctors because we don't know the technology. There's so much inequality and most of our patients do not have the resources to afford them. Most doctors don't propose the technology to patients. So the doctors just say, well, he won't afford it, so we're not going to talk about that. Just very, very wealthy people go overseas and get it. So what I've been trying to do, and now I think I've succeeded, is get someone, a big distributor, to bring the CGMs to my country. We're still working on making them more affordable or trying to get the health system to buy them, but they are here now and they weren't here 2 years ago. So I'm very happy for that.
Congratulations about that. It's an achievement. I want to add that a patient has the right to choose the combination of technologies like if there is a certain company that has a PAMA CGM, doesn't mean that applies to every patient, or a patient cannot make a combination that just works better for his daily life or whatever. Because there is also that issue after getting the access that even when we have access to the advanced technology treatments, we still need to have the choice. Entering a mobile phone store, everyone buys iPhone or Samsung and someone just wants an Alcatel or a Nokia, and that's fine. The same applies to diabetes, and many healthcare professionals are stuck in studies and researches outcomes. They just want to apply certain, let's say, recipe to every patient. I'm totally against that, because just that something works in a number of patients is respectful, but it doesn't mean that it works for everybody.
I am so glad you brought that up, and you'll not believe what I'm going to tell you right now, but my daughter is not on a pump. It's not on a pump, not because we can't, because my insurance will cover it. She doesn't want the wires. She had been with me to a lot of medical conferences because I'm always carrying my kids around. So she knew about pumps before. She knew about diabetes, CGM. She heard about all of this. And when the time came to talk about this subject with her, and she said, I don't want a pump with wires. I want something that doesn't have wires. Then we looked at those options and said, I don't want it right now. I'm okay with MDI. So we are on MDI because I have to respect her wishes. Although I am aware that she would probably be much better controlled with the pump if she doesn't want it yet, and we do it against her will, it won't work. I think that doctors sometimes forget that. We are so invested in getting them to the perfect A1C that sometimes that competes with their state of mind or their quality of mind. So right now, I understand a lot more that her state of mind, her mental health is more important at this point in time than a little 0.5 over the A1C goal we would want at this age. So perfect is probably a lot more expensive as far as mental health than okay and a little bit of a higher A1C.
Yeah, I totally agree. And also, just because we see the numbers doesn't mean that people who do not have diabetes are perfectly healthy in every aspect of their lives. It's just that we measure it every day. I had a podcast session some months ago with a dietitian, type 1D dietitian, and she said that there is a reason why the guidelines suggest 70% time in range. The next 30%, it's called life. It's called going out. It's called drinking a chocolate or eating a chocolate, always with respect to our body and our condition, but chasing the perfect may have a bigger mental health effect than good in overall health.
Yes, that's very hard to understand as a doctor because we are trained to do perfect. There's a certain personality to us doctors. We're all very structured, maybe. We all want to be the best and do the best. We get a lot of purpose in checking the boxes. There's a lesson to be learned in mental health. And I think that one of the things that I've also learned with the experience of living with diabetes at home is the importance of the mental health issues and diabetes burnout. People just get tired of being sick. I think my daughter, she's very resourceful. There's 4 people following her on CGM. She would get upset because something would go, like an alarm would go off, and each 4 of us would write to her, WhatsApp, or call her. So she made a chat, and everything that's related to diabetes is talked on that chat. You don't call her or talk to her about diabetes out of that chat. So if something happens, someone writes in the chat, and we all know that it's been taken care of, and nobody else intervenes. So there's a lot of less pressure on her. She'll, for example, if an alarm goes off and she's at school, she'll write, I already took insulin. So nobody else intervenes. And that's because it's a struggle. And if every time you see someone, the first thing they ask you is, how's your sugar? Did you inject yourself? Did you eat? Then where's the me, the person that's behind the diabetes? There's a lot more than diabetes in that person's life. And parents, we forget that because we're so worried that they have to be okay and that they're healthy. We are very worried. As a doctor, one of the most terrible things are the numbers. Are very scary. Life expectancy for type 1s is in different countries very overwhelming. The numbers are terrible. So if we focus only on the numbers, then this is a very negative thing to do. And I think that we need to do a lot more of what you're saying and try to understand that there's a life to be lived with diabetes, not because of diabetes.
You mentioned about your advocacy work about CGMs, and I would like to dive deeper and explain what other advocacy activities have you been involved since the diagnosis of your daughter, or what are you planning to do, and how you see the goal to make people with diabetes life better and easier and accessibility ensured.
One of the things we need to get, I'm very thankful for this opportunity because of this, that type 1 diabetes is a very expensive. For low-income countries as us, it will make a difference if you have money or not. It will make a difference on the type of insulin you'll get, in the ability to buy syringes, in the ability to buy supplies, and it will make a difference if you have access to technology or not. So people with more income in my country will be okay. And I have those patients. I work in the public hospital in the morning, and I work in my private practice at the afternoon. In the afternoon, people have insurance. So my type 1s, they're healthy, they have kids, they're thriving, they're perfect. I've had patients have been living with type 1 for 35 years or 40 years, and they're okay. But then I have those other patients who don't have access. So we are working on trying to find a middle ground to get access to those patients. First of all, education, then get the word out there and try to collaborate with other organizations in other countries who have the same type problems. Because, for example, in the United States, they're on the number 3 or number 7 CGM specific. We would be fine with 1. You can give me all your ones. You can donate the ones to me. We'll be very happy to get. Don't throw them away. If you've moved from syringes to pens, everybody in your country is using pen, then I'll gladly take those syringes. Because I have patients here who are reusing syringes because they can't afford it. So we need to understand that with privilege comes a lot of responsibility. We need to get our voice out there and say, we need this, and we need to get initiatives that can help us collaborate and get this to us. We are working on 2 projects, 2 big projects. One of them is a center for psychological mental health health, education, and nutritional support, because there are very few endocrinologists and internal medicine specialists who are experts on type 1. So we don't have a lot of time with patients. We cannot touch on all of the things we need, the meetings, on the consultations. So help with these issues, someone else to incorporate in the team. So we're working on a big project and trying to get funding for that, to build a building for the rest of the diabetes support. And right now we are trying to work and try to legislate around a law that obligates the government to give them supplies. We do have insulin and it's almost free. You can get regular insulin for about $2 or less, like $1.50 in my country, in the public. So we're getting there. We have better access than some other countries.
What you said about if you're advancing in your technology in a developed country, you can send the older technology to a country which is suffering, and that will make a total difference in so many people's lives. In my country, let's say a CGM advanced from a level to another, they increase the price of the previous level just so that the profit increases. We're not as independent as we would like to be. Healthcare is a human right, insulin is a human right, and accessibility is a human right, no matter what company or people who are profiting. And also, I want to add to that believing that your management is good may be a result of things that you were just privileged to have. And if you're privileged enough to live in a country where you have accessibility, where you have enough money to buy quality food, where you have the money or the healthcare system supports you with a psychologist, a team, your management will be good. But at the end of the day, your effort is so much less, and the privileges in which you live are the ones that make the difference.
Even in developed countries, we are amazed. We live so close to the States and we get a lot of information. It's very difficult for us to understand that developed country has patients who are having trouble getting their insulin. I think there's a lot to be done as far as advocacy to try to make insulin for everybody accessible.
Moving on, I would like you to share some tips or maybe personal experiences of how you manage your daughter's type 1 life to other parents living with their type 1 kids.
One of the best advices I got when my daughter debuted was from one of my type patients. So I told him, and he's been living 40 years with me. He said in his own words, "You are not her doctor, you're her mom. Be her mom." That resonates in my head a lot. So I actually go to the doctor. We have a pediatric endocrinologist, which we go to, and he's the one who tells her most of the stuff that you don't want to hear from your mom. I do the mom things like put your sweater on or eat your food. We have to go to practice even if you don't want to, like I do with my other son. I think that the best advice as a doctor that I would give to a parent, and as a parent, what I'm trying to do is to raise the same kid I was going to raise as far as my ambitions for her, what I would want her to be in life. And I told my husband the day after she was diagnosed, I said, you know what, I don't know how, but I know that the people who manage to have a very fruitful life with type 1 are those whose parents raised them as normal people, quote unquote, because you are not bound by the diabetes. You are supposed to learn to integrate the diabetes life on your normal life. So she has responsibilities, she has her chores, she has her studies, she has to do everything else that she would have to do or enjoy. We do everything the same. There's no special food in the house. All eat healthy. We've done that before because I'm an endocrinologist, so we try to eat healthy at home. I think that the only thing I've allowed, we didn't, was diet soda. I didn't give them soda. But you see, that's the kind of flexibility you have to allow, because sometimes we go out and there's nothing else, so she'll have a diet soda and it's okay. It's okay. I think that the best advice would be that you don't have to allow the condition to define your kid. You have to raise the same kid. I tell her sometimes there's bad moments. It's not peaches and cream. I tell her, you know what? You're not sick. Do you feel sick? When you have the flu, you're sick. You feel your nose is runny and you have a cough. Right now, are you sick? Oh, you live with a condition. And if we manage this condition, you're going to be okay. We struggle and sometimes we just sit and wait till the dark cloud goes by. We have good times and bad times, but we're trying, as any other little girl and the same powerful woman I want to raise, she's going to be that.
That's very wise. I was raised the same way. My parents later told me that they didn't want to let diabetes be an excuse for me, but a bad excuse. I have a bad character or bad behavior. It's because of diabetes. It's so easy to blame diabetes for everything because it literally affects everything. And if you see a person with diabetes having a hypoglycemia, you may understand it.
Yes.
To blame the condition about things that happen in your life is like giving the authority to the disease to define and dominate your life.
It's victimizing yourself.
Yeah.
And I agree completely. Like if she'll be in a bad mood, she herself will say, you know what? It's not me. It's not you. I'm just low. So give me a chance. I'll be better. Sometimes she's just in a bad mood. She's 10. And I'll be like, yeah, you know what? We're not standing your bad mood. It's your problem if you're in a bad mood. We don't have to take it. So I think you have amazing parents. I think that it's influenced a lot, Kona, by what parents do and the community that we as parents build around ourselves, because it's not us, only my parents or everybody in our family. She was diagnosed a Thursday, and that weekend, everybody that's very close to her, like my nephews, all of my cousins, gather around her, and my aunts and my uncles and her grandparents. They said, what do we have to do? How do we give her insulin? What do we have to do if she's low? We had a class. I had a power. We had a class for the whole family, and I taught them what they should do. I think there's a community around. Then we talk about taking diabetes to school, how that influences how your classmates react. You have to transmit the fight. I mean, she's from a third world country and a woman. She has to be a fight.
The last words were so emotional. I would like to emphasize on the challenges you would like everyone to know about family or people with type 1 diabetes in your country. How do you see the future of healthcare in your country regarding diabetes?
So I think we need more endocrinologists. We need more internal medicine and pediatric specialists who take care of these patients, because we need more access, like local access. People have to travel a lot to get to their doctor, and the appointments are too far away. They should be less separated. We're starting next year a specialty consultation in my hospital twice a month. We're going to have only type 1s for 1 day a week. Hopefully with that, we're going to get better care for them. The other thing we need is more technology and make it accessible. And I'm sure that if we get, and I always compare it to phones, if you get the number 10 instead of the 16, it's more affordable, and you're going to do better than nothing. I think we need that. We need to build bridges with people who are doing great. I think that there's a lot to be said for community. In type 1, I've learned the value of community. I follow a lot of Instagram accounts of patients, more than parents. I follow patients because I've learned so much through their wisdom. I listen to them. When they come to consultation with me, my patients, they ask me about how I'm doing. So I think that a much better doctor, since my daughter was diagnosed, I'm sure of that. I think that we need to get a lot more of that kind of information out there, not just locally, but globally. I actually have proposed a talk. I'm going to try to get it into the next local endocrinology meeting. The talk is going to be called Diabetes from the Other Side, just to try to get my colleagues to understand how it feels from the other side. Have them believe me that sometimes they're just scared and the blood sugar will go up 250 points without eating because you're scared or stressed or you have a test or you're really happy. It goes up when you're really happy too.
Yeah.
So I think that needs to be more addressed, and we need legislation. We need to make it obligatory for countries and governments. We need to work more on that. There's a lot to be learned, Kona, from AIDS and how they advocate for their patients and how they've worked to make, in my country, people living with HIV have their medicine secure. There's no way they're not going to get their medicine because there's legislation around that. So we need to get that for type.
Great. I'm looking forward to achieving those milestones in your country. What if your daughter says to you that she wants to become a doctor? Gonna happen?
So we went to this Medtronic, I'm going to say the brand, but we went to this bump meeting with my husband. It was in a very nice place, so we made it a holiday. Everybody was wearing a CGM in the hotel, and my husband was like, all these people type 1 in Emilia. She's a nutritionist, she's a psychologist, and he's a doctor, and she's a nurse, and they all work in healthcare and for type 1. So you know what? This may happen.
It's probably going to happen.
My lesson for her, she can do whatever she wants if she puts her mind into it.
How would you react?
I would support it.
Yeah.
Completely. She says right now that she wants to be a veterinarian because she doesn't like people. But she likes animals better, which is okay. We'll see.
We have seen dogs with CGM.
I wanted to be a doctor since I was 11 or 10. I'm the head of the endocrinology service in my country, in my hospital. I have a type 1 who's finishing medical school in his last 6 months of internship. He is in charge right now of building the type 1 adult and kid community. That's his main job. That told him, I'll allow you to work with us, but you have to do this. And I think nobody will do that better than you. So he's working on it. I do have a lot of experience with my patients going into the medical field. He was listening to a conversation yesterday where one internal medicine resident stopped the residency because of the diabetes. She was a type 1 and she had severe hypos and she decided to stop, to not continue. I saw his face, like he was disappointed to listen to that. And I said, but yeah, she probably didn't get the help she needed because there's a lot of ways for that to happen. I think if she would have talked to me, I would have helped her. I didn't know this. They were just telling me the story. And he wants to be an endocrinologist too. I think that will probably, I can help.
Yeah. Before closing, I have one final question. One piece of advice to a newly diagnosed type 1, one piece of advice to every endocrinologist or healthcare giver, provider working in the field of diabetes. So 2 advices.
For a type 1, do your mourning. Allow yourself to cry and mourn your old self or whatever idea you had of yourself. And after you do that, over those ashes you built. Don't ignore it. Don't allow yourself to be told that it's okay and you're going to be okay, because it's not. It's okay not to be okay. For us as medical professionals, I think it's extremely important to understand that we are not going to get to the goals, to the A1C, to the time range, to the everything we want to if we don't allow for a team to work with us. That team must include mental health. If we underestimate the importance of that, we are not going to have the outcomes we want. No matter if you have the best CGM pump or insulin, if your mental health state is not good, that patient won't thrive. That would be my advice.
Thank you very much. I enjoyed this conversation a lot, and I appreciate that there is a quote in Greece, and I think it's global, that the more you learn, the less your ego becomes. But that usually doesn't happen with doctors. I don't know why this rule excludes doctors, but I see that you're included in this rule. It's so nice because both as a patient and a new work medical doctor, I've seen so many toxic behaviors from seniors to juniors or from doctors to patients, and I see that you don't have this mindset and this approach, and that gives me hope because finally it's a choice. I mean, it's a choice how you react to the stress and the work overload and how you're gonna approach people who may be left behind. You said a resident was about to quit due to hypos. In my country, I know that there is medicine and also patient management is a system, but that doesn't mean that there are no exceptions to the rules and that there are no other path to follow your dream. I'm so glad that you encourage people, both as a medical doctor to juniors, but also as a medical doctor to patients. I think you're an example of how people should behave generally.
Thank you so much for those words. And I do believe that I agree. The more you learn, the less you know. My arrogance as a newly graduated doctor or endocrinologist has changed a lot. I would like to say that I have a lot of mentees. I work with a lot of young people. I try to tell them, you know what, we need to remember that we have this God-given gift of helping people. Our knowledge is only going to be as effective as your heart is. Because if you let yourself be intoxicated and forget that we are just human, no matter how much money you have or how much knowledge you have or how many PhDs or awards, we all die. We all die.
Let's be honest.
It's going to happen.
Again, thank you very much. I wish you all the best in your career, in your project. I wish also all the best in your daughter. I think she's in so safe hands. She will appreciate that maybe a decade later. But I'm sure she will. I'm sure she will. After your 20s or 20s, you start appreciating everyone and just valuing your parents in a different way than just saying what they did wrong when you're younger. So I'm sure that she'll come to that point that she will understand what you're doing now and how difficult it is to be as ethical as you are towards to her, because it's more painful than just restricting her and putting her into boxes, let's say.
We all do. We all appreciate our parents when we get old. Just wisdom.
Yeah.
Thank you so much. And I am very happy to meet you. I will tell her later on I had this conversation with you and tell her, you know what, there she is struggling with not eating and not sleeping and feeling dumb half of the time because we all do. Yeah. That has nothing to do with the type 1.
Yeah. That was nothing to do. And let's say we just have a box of juice around every time we just feel a bit dizzy, but that stops us from nothing.